I'm saying hello from Kalamazoo, Michigan, where it's a beautiful fall day, and I would like to thank Kura very much for allowing me to participate in this, and most of all, each and every one of you for taking time out to join us. Look today, we'll take a close look at some of the most common special stains. We're going to learn why and on what we might use them. We're going to look at what happens during some of the processes, and I've thrown in some generic protocol and troubleshooting that I gathered from folks just like you throughout my years of work. Now, if you have any comments or questions, just jot them down, and we'll share them at the end of this, okay? But anyway, we're going to get started with we're going to define special stain. A special stain is a group, a significant number of alternative staining techniques that are used when the H&E does not provide all the information needed to unlock the secrets of the tissue sample. Now, we all know that about 95% of all diagnoses are made from an H&E, but when you just can't do that, then you have to resort to other methodologies. So these special stains that we're referring to actually use dyes and chemicals that have affinities for particular components that are to be distributed or demonstrated. So special stains allow the presence, and in some cases it's more important to see the absence of particular cell types, structures, microorganisms. Just to clear up any confusion, though, we want to make sure that we understand how a special stain versus an immunostain. Immunostains are not special stains. Special stains are empirical. In other words, somebody did some testing, they did experimentation, they did observation, they had ideas about things that might attach to certain organelles, etc. They just happen to work. After all this trial and error, they're able to produce a protocol, whereas immunostains are defined by an antibody of known specificity. Now that we have targeted therapy available, such as Herceptin, we need tests that shows the diseased cells or tissues are have this. We have to have visualization tests to show this, like HER2/neu, for instance, for the treatment of Herceptin. Today we're going to look at procedures for carbohydrates, which include mucins, glycogens, connective tissue fibers, which include collagen, elastic fibers, and reticulin fibers. We're also going to look at some microorganisms to include bacteria and fungus. We're going to start with mucin. Now, there are many, many, many stains out there that simply exist for the purpose of demonstrating one or more of the mucopolysaccharides next found in a particular sample of tissue. Keep going. Mucopolysaccharides equal mucin, which equal long chains of sugar molecules found throughout the body, and they are essential for life. They play important roles in cell growth as they regulate flows of nutrients between capillaries and cells. They are described as the glue of life. That's not how I would describe mucin, but that's what they say, the scientists say, the glue of life. Two broad categories of mucin. Acid mucin, they carry a negative charge on the mucin molecule. There are simple acid mucins, and there are complex acid mucins. They are found widely distributed throughout the gastrointestinal and respiratory tract. The second broad category is neutral mucins. They lack an acid group, so they carry no charge. They are found in stomach epithelium, glands in the small intestines, and prostate epithelium. If you look, you will see that it appears that the acid mucins occur a lot more than the neutral mucins do. So there are stains that we use to identify mucin. There's the Alcian Blue, there's the colloidal iron, and there's the mucicarmine. And I'm sure you've noticed that I've done some little color association there. We're going to start with Alcian Blue. Alcian Blue is a basic dye. It contains copper. That's what gives it its blue color. The stain molecules carry a positive charge and are attracted to the negative mucins. They do not, however, Alcian Blue does not stain neutral mucins. Adjusting the pH of the Alcian Blue, you might wonder, why do we do a 2.5 as opposed to a 1.0? Well, the 2.5 is considered a comprehensive mucin stain because the carboxylated mucins, which means they simply just have a carboxyl group added and are low in acidity, appear and occur more than the sulfated mucins. This will stain connective tissue, cartilage, goblet cells, and Barrett's esophagus. And at 1.0, it stains most sulfated mucins, which are considered high acidity. 2.5 stains simple, and 1.0 stains complex acid mucin. Things that normally stain positive with Alcian Blue, we've got acid mucins, goblet cells. Here's a picture of some intestinal goblet cells which produce acid mucin. There's your Barrett's esophagus and the goblet cells which stain. Remember, they are a simple acid mucin. Also stains mucoid capsules of organisms, Cryptococcus. Now, disease processes are identified with a positive Alcian Blue reaction also. So we have our mucinous tumors. Now, the word mucinous oddly means that something has a lot of mucus. Carcinomas that are comprised of at least 60% mucus are referred to as mucin. Now, mucinous tumors are very interesting because scientists think that the presence of mucus allows cancer cells to spread faster. So as a result, these mucinous carcinomas are considered more aggressive, they respond worse to treatment, and their prognosis are not as good. So mucinous tumors comprise about 10 to 15% of all adenocarcinomas. And we all know out there that adenocarcinoma is a cancer of epithelium that can originate in glandular tissue basically anywhere in the body. Nearly all breast cancers start in the ducts or lobules. These are glandular, therefore they are termed adenocarcinomas. And here's an example of mucin-producing conformation with the aid of an Alcian Blue stain. Here's a little chart that I actually put together, and yeah, we're missing a couple of places there, but this kind of gives you an idea of why you use which one. If you got the tissue type, say the GI tract, like the lower GI tract, and you've got glands, well, those are neutral mucins. And we just saw prostate epithelium on the list of those that are neutral mucins. So they're not going to be stained at all by Alcian Blue of 2.5 or 1.0. Then if you go to your goblet cells, epithelial cells, goblet cells, those are simple acid, and they're going to be stained positive with 2.5 and negative with 1.0. An adenocarcinoma is a complex acid mucin. It's going to stay negative with 2.5 and positive with 1.0. Now, can we demonstrate acid and neutral mucins with one stain? Well, if any of you are shouting out there, yes, we can with an Alcian Blue PAS, you are correct. Here's an example of why you might use it. This is a slide of Crohn's disease. You got gastric cells that are staining blue with acid mucin, and then you've got these epithelial cells that also look like gastric cells, but they're associated with the ulcers that sometimes appear in Crohn's disease, and they are staining because they're neutral mucins, they're staining with the PAS. So Alcian Blue, like I said, I threw in some generic processes or protocols. Simple stain. You just get the pH right, and you run it down, you incubate it, and wash it, and counterstain it. Simple. These protocols are mostly for you to have in case you want to try some, or you don't have a good protocol that works. Any one that I show you has been tried and tested and works very well. As far as troubleshooting goes, the one big thing that I noticed in laboratories is if you allow your nuclear fast red to sit around for a while, whether it's in Copeland jars or whether it's in a larger container, and you don't mix it, it tends to, the stain falls out of solution, and it tends to give you kind of a muddy-like little background or too light, messes up your stain a little bit. And of course, now that you know that some things don't stain with certain pHs, you know to check out the pH of the Alcian Blue and make sure that you have the right one. Colloidal iron. So guess what? It's used to distinguish acid mucins, and that's just what we went through with the Alcian Blue. So colloidal iron is often replaced. It will replace the Alcian Blue because of its greater sensitivity for acid mucins. So if you've got something that failed the Alcian Blue test and yet you're pretty sure that we've got some acid mucin there, then the colloidal iron is probably what you want to call on or do first, because it can detect extremely small quantities of acid mucin. Mesothelioma, which we've all heard of because of the lawyers on TV exploiting, the asbestos, the exposure to asbestos. And it's a rare form of cancer that develops in the mesothelioma, or the mesothelium, which is protective lining that covers a lot of our internal organs. It is, in the past, was very difficult to detect, and still is in the early stages. Now there are biomarkers that can detect it, but also colloidal iron was used to detect it before some of these became available. Colloidal iron is positively charged iron ions. And of course, just like everything we looked at so far, they're attracted to the negative mucin molecules. So the attached iron ions are then treated with potassium ferrocyanide to form visible bright blue deposits. The excess is washed out, and this is kind of what a colloidal iron looks like pictorially. The acid mucins bind the colloidal ferric ions at very low pH. That's the reason you go into a 12% glacial acetic acid before going into colloidal iron, because you want to get it to that low pH. Then you've got Pearl's iron solution. It deposits a dark blue pigment at the sites of the bound mucins, and you incubate in NFR until you get the desired background, and you got it. So there's your procedure, and that's what it looks like, your results. You've got acid mucins looking deep blue. You've got your pink-red nuclei, and your cytoplasm is pink. It's really a very pretty stain. So colloidal iron troubleshooting. Well, I could have added one other thing here if we were back in the day that I came from, because we used to have to make our colloidal iron. Anybody out there who still makes colloidal iron, raise your hand. I won't see it, but if you do, I feel so bad for you, because that's the hard part of the colloidal iron procedure. That now that you can buy it pre-made and tested, it makes life so much easier, but you still might run into an issue. Back it up, back it up. You still might run into an issue of nonspecific hemosiderin, and it might get in your way when you're trying to make a diagnosis. So what you can do is run 2 slides and just incubate one with potassium ferrocyanide, and then when you analyze your test tissue, you disregard the staining that may have occurred on the separate slide, and it might help you to weed out what's real and what's not. So if we think back in our minds, and I know some of you out there are really young, just out of school, just starting your careers, but if we think about in the land before IHC, what did we do? And what happened again, like I said, some really smart people, like this caveman, got together with some weird-looking beetles called cochineal beetles, and they kind of smashed it up and got some powder, and then the scientists came in and did some mixing, and they discovered or created mucicarbine. Mucicarbine is a very specific stain for mucin of epithelial origin, like this lung adenocarcinoma that you see. We used to have to kind of be on the watch out for this thing called signet ring cell carcinoma. It was fairly easy to slip by sometimes in H&Es, and oftentimes when a pathologist saw a sign of it in an H&E, he would request a mucicarbine. And you can see going from the H&E up at the top to the mucicarbine here in the middle, and then now going down to the bottom where you've got the carcinogenic embryonic antigen, antibody. So that's where we've come from, possibly missing it with the H&E, showing it with the mucicarbine, and even more so proving it with the CEA. So mucicarbine, it also can demonstrate the capsula Cryptococcus neoformis, which is an opportunistic fungus, most often found in immunocompromised patients. So we can do that with the Alcian Blue, we can do it with the mucicarbine. Remember the beetle. So if we think about hematoxylin, all right, and if we look at the logwood tree and we just scrape us some hematoxylin off the logwood tree and we mix it with water, it doesn't do anything as a nuclear stain. But when we add it to a mortantine compound, some aluminum salts, it makes a terrific nuclear stain. This is kind of what happened with mucicarmine. The carmine is bound into solution. Those beetle powders are bound into solution with aluminum salts, and it makes, it attaches then to the tissue. So the positively charged complex is then attracted to, guess what? The negative mucin molecule, and we end up with staining. Here is a pictorial view of mucicarmine. One thing I want to say about this, if you notice there, first of all, obviously we stain the nuclei in whiters, and we go get our stock carmine, and we do a working solution, 1 part of stock to 3 parts water. Have any of you ever become frustrated with mucicarmine solution and just put it right into the stock carmine? Well, it really doesn't help your situation, but I will tell you about a lab I was in one time that their mucicarmine just wasn't working, and they were diluting it with still water and no reaction, very little reaction. Come to find out, the manufacturer preferred that you mix it with tap water. And when they started mixing it with tap water, they started getting fantastic results. So anytime you have questions about that type of thing, you should contact your manufacturer and see if they can give you a little insight. But again, we see that the mortantine effect is here, binding this solution to the acid mucins. Then we do a counterstain, and we've got our beautiful mucicarmine, which you can see right here in this colonic mucosa picture, just gorgeous, gorgeous nuclei, beautiful mucicarmine staining. And there's a typical procedure for a mucicarmine stain. Really not too difficult as long as all your components work. All right, next we're going to flip to the next type of carbohydrate on the list, which is glycogen. Okay, remember that mucin is the glue of life. If mucin is the glue of life, then glycogen apparently is the fuel of life, because glucose is the main source of fuel for cells. If you have an excess, it is stored in the form of glycogen in your liver and in your muscles. So when the body is not getting enough glucose from food, it will break down the glycogen to release glucose into the bloodstream. So I don't know if you've ever, watched your weight or been on a diet or did something crazy like fast. Eventually, your body will eat your muscle if you're not careful. So just remember that. So glycogen is the fuel for cells. The stain of interest for the glycogen is the PAS, the pyrotic acid shifts. It's used to demonstrate glycogen in the liver, certain tumors of the bladder, kidney, pancreas, and ovary, also basement membrane in kidneys as well as in skin, fungus, and oh yeah, some epithelial mucins, which we know as our neutral mucins. The pyrotic acid shifts is the most versatile of the stains mentioned so far, because unlike the previous stains, we can recognize neutral mucins. We can also recognize non-sulfated acid mucin of epithelial cells. The PAS does not rely on the acidity and negative charge on the carbohydrate molecule, but on the structure of the saccharide unit itself. So some things that normally stain PAS positive are fungus. A lot of people use PAS as their go-to fungus stain. Basement membranes, again, of kidneys and skin, that's kidney glomerulus. The presence of glycogen and its distribution patterns are significant in diseases such as like glycogen storage disease of the liver. I know we've all done PASs on livers, whether it's from autopsy or liver biopsies. Then you've got Pompei's disease, which isn't as common as glycogen storage, but it's basically glycogen storage in your muscles that affects almost every muscle in your body, including heart and skeletal muscles. Okay, so carcinomas, many types of carcinomas. For instance, rhabdomyosarcoma, that's a rare cancer. It will display glycogen positivity. Mesotheliomas. Here's a pictorial view of a PAS in action. if you look, the first thing we're going to do is we're going to oxidize it in pyrotic acid. We're going to form these aldehyde groups that you see off to the left there. Then we're going to incubate them in shifts, which contains basic fuchsin. Basic fuchsin binds to these aldehyde groups, and then the water will help to turn these this color pink to red, but it doesn't create aldehyde groups. So the intensity of stain doesn't really depend on how long you leave it in water, but it depends on the concentration of the aldehyde groups in the sample. So that's why it's imperative that you have fresh pyrotic acid, and if you look in this procedure, it's calling for a 0.5% solution. There are many procedures that call for a 1% pyrotic acid solution, so one might imagine, based on what we just talked about, that might intensify the number of aldehyde groups that would be available to pick up the shifts. So as far as troubleshooting, we just talked about it. Time, percentage, pyrotic acid can manipulate it. Most shifts should be stored in the refrigerator, so read your package insert. What a lot of labs will do is take their shifts out in their Copeland jar or their larger container, use it, then put it back in the fridge overnight, and normally that lasts for quite a while that way, but your package insert is your best guide. Okay, when do we digest or we don't digest? So, go for it. So we use diastase as our digestion enzyme. And this is a malt extract containing alpha and beta amylase extracts. In the old days, as you know, I don't want to gross you out, but we just spit on the slides. But if you're doing, 500 slides a day, that probably wouldn't work the best. But the enzyme aids in the converting of starch into sugars. So what the diastase does is it breaks down glycogen into smaller groups, which are then washed out of a tissue sample. So how do you run a proper diastase digestion? A proper diastase digestion requires 2 slides. So you want 2 identical pieces of tissue on 2 separate slides. You're going to treat slide A with water or buffer, while you treat slide B with diastase. Then you're going to stain both slides with PAS. And you're going to get something that looks like this. Slide A will show a strong PAS reaction. Slide B shows, it might show it if you have PAS or if you have glycogen. Slide B disappears after diastase digestion except for just a little bit. So interpreting the results, basically the areas that are PAS positive in the untreated slide A and PAS negative in the treated slide B are assumed to be glycogen. So just put this in your head that glycogen is digested out. There might be other material there that's not glycogen but still PAS positive and was not broken down by the enzyme. Okay, we're going to move on to our next group. We're going to move to connective tissue. So connective tissue, so we have mucin, the glue of life. Glycogen is the fuel for life. So now we've got connective tissue, which actually holds us all together. We've got 3 types we're going to look at. We're going to look at collagen, elastic fiber, and reticulin fiber. Collagen is the most common type, and it can be visualized with an H&E. Collagen is a strong protein. It's the main component of ligaments and tendons, and it's responsible for that wonderful skin elasticity, which I can assure you does decrease as you get older. So elastic fibers, we're going to come back to collagen, but elastic fibers, they're located in the skin and walls of blood vessels. They're composed of a protein called elastin. It's flexible, and it allows many parts of our bodies to resume their shape after stretching. When you smile, when you frown, when you make your forehead have wrinkles in it and it pops back, that's because you have elastin. It's not visualized by an H&E. So reticular fibers, the last one, they're composed of collagen. And these fibers form net frameworks around nerve cells or nerve fibers, fat cells, lymph nodes, smooth and skeletal muscle fibers. They are not visualized by an H&E. Stains for connective tissue fibers, again, color-coded. We have the Mason's trichrome, we have the Armasons, we have the Gomori's one-step, We have the elastic tissue stain and the reticulin stain. So trichrome uses 3 dyes and selectively stains muscle, collagen, fibrin, and erythrocytes. Trichromes are used to stain liver biopsies to determine the degree of fibrosis and cirrhosis, kidney biopsies to accentuate basement membrane and demonstrate immune deposits. It's to differentiate between smooth muscle and collagen in tumors, and to verify increase or decrease of collagen. Here's a pictorial of a trichrome. Again, we're going back to that concept of mordancy. In this case, Bouwens acts as a mordant to bind the stains to the tissue. Now, Weigert's doesn't need Bouwens, but Biebrich Scarlet definitely needs Bouwens, that mordant, to react with the muscle. And in this case, it will stain the muscle and the collagen all red. So what we have to do then is we have to diffuse out the collagen. We want the muscle to be bright red, but we don't want the collagen to be purple when it's blended with the aniline blue. So the phosphatase phospholipid acid diffuses out the red from the collagen, making it acceptable to the aniline blue, and we get a nice blue collagen and a great differentiation. We use 1% glycolic acid to differentiate the stain at the end. Here's a kidney showing immune deposits, much like you might find in lupus. Now, this is a Mason's trichrome. It's granted not the best one I've ever seen, but it does show the immune deposits. And here is a example of a one-step trichrome. One-step trichromes can either come in blue and green or red and blue. Red and blue mimics what a trichrome, Mason's trichrome, looks like. The blue and the green is a little bit different, but you can actually see a little bit of muscle in between the blue collagen. It's a bright stain. A lot of people use it. A lot of people like it. And again, here we go. This is what it looks like. This is what the one step looks like, because what we've done is we've taken Biebrich Scarlet, phosphatase phospholipid, and aniline blue, and in this case, though, we've used something green instead of red, but that could easily be red. And so it's a much shorter stain and not involving so many components. So there's the Masons. You can basically, get rid of, change 3 steps to 1 step by using a 1-step. Now, troubleshooting the trichrome. The biggest problem in the trichrome normally is that the muscle is not intense enough. That's the problem that I have heard more, and it's directly related to the viable Bouwens that you use. You make sure it's the right time, it's viable, and it's the right temperature. And then the collagen is definitely dependent on good differentiation with the phosphatase phospholipid. Now, elastic tissue. First of all, before I go into elastic tissue, I just want to let you know that those stains that we have looked at so far all lend themselves extremely well to automating on open staining systems. So meaning if you are having issues getting certain special stains out that you have a lot to do with your H&Es, then these are stains that you can easily stretch out the volume of and stain 20, 30, 40 slides at a time and get them out faster by automating them on an open staining system. Okay, so elastic. The most common procedure used in Verhoef's elastic stain, or the most common procedure is Verhoef's elastic stain or Verhoef's Van Giesen. Now, elastic stain is used to identify atrophy or elastic tissue as in emphysema. Atrophy of elastic tissue as in emphysema, evidence of the vascular diseases, and invasion of tumors into vessels. Here's a picture of how it works. We make this special hematoxin, this Verhoef solution, and so we have our Weigert's iron solution, and it also has a mordant like the iron chloride or the iron chloride, and we differentiate. It's actually ferric chloride. We also differentiate in it, which breaks the mordant dye complex. So what it does is it takes out the excess. It leaves the elastic tissue still binding this kind of black color, but you can overdo it. So you don't want to over-differentiate or under-differentiate. This is where sometimes eyeballing it at this stage is really good if you want to be precise in the way your stain turns out. Then you're going to remove the excess with sodium disulfate, counterstain with Van Giesen. All right, so here's a picture of some elastic fibers. Van Giesen being made up of picric acid and acid fuchsin, you're going to get your collagen stained with red and your muscle stained with yellow. And you can see those intense fibers, the elastic fibers. Here's an example of a genetic disorder of the connective tissue, and you can easily see the moth holes, the kind of rat-eaten areas in this Marfan syndrome, and all the nice elastic tissue on the left-hand side of the normal aorta. Here's just a procedure for elastic stain. Again, the most important part is that differentiating 2% ferric chloride, because if you look at the second statement here, the dye molecules love the ferric chloride equally as much as they love the tissue molecules. So they're just apt to jump off the tissue molecules and kind of blend in the differentiation solution. So this is a little bit of a touchy step. The other thing that's real important is the Verhoff needs to be fresh each time because it rapidly oxidizes. So if you look at it, if you hold your Copeland jar or your solution up and you look at it and you see that it is brown, you need to throw it away because it's supposed to be a beautiful, rich, royal purple, and it will give you beautiful results. The brown will not work, it's over-oxidized. Again, don't leave it too long in Van Giesen because the picric acid will continue to differentiate out the stain in the elastic tissue. So it's kind of a little touchy stain, but easily, done successfully. So reticulin. Reticulin fibers support the body and are common in liver, spleen, and kidney. Characteristic patterns can help diagnose cirrhosis of the liver, fibrosis in bone marrow, many tumors, epithelial versus non-epithelial tumors. So reticulin stains use silver, and they rely on our gyrophilic properties. Okay, how many people know what our gyrophilic cells are? Well, I can see your hands. That's great. Our gyrophilic cells cannot absorb solution. It can't permeate it. So what happens is with our gyrophilic cells, things can cling to the surface. So it's all a surface-based process. It can't reduce the silver. So it basically needs a lot of help. So this is it in a nutshell. So the fibers have no affinity for silver. They have to be oxidized. They use potassium permanganate to oxidize it. Then you use the oxalic acid, which comes next, to remove the purple that the tissue takes up. Everything is purple when it comes out of potassium permanganate. And the most important step is the ferric ammonium sulfate sensitizes the cell sites and binds to these sites. Then the silver ions in the ammoniacal silver solution impregnate the fibers, replacing the sensitizer with metallic salts. Now, if we left it at this stage, you would never be able to see the reticulin fibers. That's why you put it into a fairly strong, about 20% formalin, which reduces the silver to a visible metallic form. It's toned in gold chloride for stability, and then we use sodium thiosulfate to remove the unreduced silver. Here are pictures of it in the liver, showing the reticulin fibers and a slightly red background from the NFR. There's the procedure, fairly long. A lot of people now do these on closed system stainers. So troubleshooting. All right, silver stain does need to be made in clean glassware. It doesn't have to be acid clean like we used to do it. And the most important part of all is don't put too much ammonium hydroxide when you make the silver because you will cause the reticulin fibers to be diffuse and they won't jump out on the slide. So best practice is, yes, you can put a larger quantity in it and then kind of drop by drop, but make sure you don't overstep with that larger quantity. When you're done with mixing the silver with the sodium hydroxide and then adding the ammonium hydroxide to it to clear it up again, you want to make sure that you have some little black pepper-like flakes in the bottom and leave those in there, just a few dozen. And that means you haven't overdone it with ammonium hydroxide. It's a good way to check yourself. And I know places, laboratories where they'll make up 1,000 ml of this ammoniacal silver, put it in a brown bottle, and keep it in the refrigerator for a month, and just pull it out when they need it. And it seems to work. It seems to be very stable. Microorganisms is the last thing we're going to look at. And so we're going to go on for microorganisms. We're going to look at bacteria and fungus. We're going to look at two groups of bacteria. One is the Mycobacterium tuberculosis, which we probably all know and hear about it. That, it still kills 2 million people annually. Probably not here in the States, but, it's still something you have to be careful with when you're doing frozen sections on lung tissue. So this bacterium is non-motile. It's rod-shaped. And the preferred stain is one of the forms of the AFB, either the Kenyon's carbofuchsin or the Mucin. But in any case, they both use a carbofuchsin, which is really messy and doesn't really smell too good either. But the great thing about this bacterium is that its cell walls have an acid-fast property. It produces a waxy substance called mycolic acid. The mycolic acid links with substances in the cell walls, making them resistant to decolorization by acid alcohol after you remove the excess carbofuchsin. So this is what it looks like scientifically, but my scientific example of it is, imagine that you have this rod-shaped bacteria and you encircle it with a lobster trap. Well, we all know that when we put a lobster trap in the ocean, that the lobster goes in, but the lobster can't come out. That is basically what happens with this mycolic acid interaction with cell walls on this particular bacterium. So once the carbofuchsin goes in and it goes into acid, it's protected by the lobster trap, so it can't come out. So there are very few really true acid-fast bacteria. Nocardia is one. The rest of the bacteria will just be decolorized and it will stain blue, and you'll just never see it unless you don't put a counter stain on it. So there's a picture. I know we've all seen this. That's our lobster trap. So it's a simple process. You stain the carbofuchsin, you decolorize, you stain the methylene blue. So don't be afraid to leave it in your hydrochloric acid long enough to get rid of all the blotches of, there's nothing worse than having little splotches of carbofuchsin still on your slide to mess it up for you. So just get it clean. You've got time. It's not going anywhere. So here's a procedure, pretty simple. You have to be careful with the methylene blue because it'll wash out quickly in alcohol. So you may want to just kind of limit that time or limit the number of alcohols. Okay, so the next microbacterium is the one for leprosy. Now, it's a little bit different than the one for TB. Different stain, Phytes sphaerico or Faraco, depending on where you live, is the preferred stain. There are still 250,000 cases reported each year. According to a 2014 report, it's probably about the same now. Now, this bacterium has the same mycolic acid waxy cell walls as the Mycobacterium for tuberculosis, but it's much less acid and alcohol fast. Hence, you have to use a process that removes alcohol from the picture, so you can't run it down through alcohols in the beginning, and you can't dehydrate it. And you use this weird concoction with peanut oil and xylene. And it took me forever to figure out why we're doing this. So obviously the xylene is going to de-wax the slide to make sure that we don't have paraffin going down. But the peanut oil, if we go back to our picture of the lobster trap around the bacterium, in this case, the lobster trap is not 100% effective. It lets the lobster in, but it lets the lobster out. So the peanut oil provides a disc of protection around the lobster trap so that the lobster goes in and now it can't get out because we've got this extra layer of protection. So if we follow suit and keep it out of alcohol, then we should be able to show the leprosy bacterium. It took me forever to get one of these right. That's all I can say. So AFB, don't overstain with methylene blue because you can mask the positive bacteria. If you get too much in there, dip it out, in 95% alcohol. Some of it will be removed, but if you just flat overdo it, you just probably might as well do the AFB again. But other than that, it's really, really hard to mess up an AFB. Not on leprosy, but on tuberculosis. Okay, Helicobacter pylori. So did you know that over 50% of the world's population has some of this in them? 80% of the infected population have no symptoms. Those infected have a 10 to 20% lifetime chance of developing peptic ulcers, 1 to 2% of acquiring gastric cancer. So your odds are raised a little. So H. pylori is spiral shaped. It's associated with gastric inflammation, peptic ulcers, gastric carcinoma. And by the way, you don't have to be old to have this either. I know some 19-year-olds that are infected with it. The preferred stains are the terrible Warthin-Starry silver stain, Giemsa, and the IHC, which is the most sensitive. So the Warthin-Starry, and I say, the terrible Warthin-Starry, because it can be a difficult stain to do. I'm imagining that most people who do very many of these are probably doing them on a closed system stainer because there's a lot of things that can go wrong in a Warthin-Starry, and they're a lot of work. But they also, like the reticulin fibers, rely on the argyrophilic, properties of the cells. They cannot absorb nor reduce silver. Basically the same thing as a reticulin, and this is also used to demonstrate spirochetes. Steiner stains rely on similar mechanisms. So these are just some protocols. I didn't spend a lot of time on this because, like I say, most people are not even doing this too much manually anymore. And if you are, I'm hoping that you have a really good procedure. This is why the doctor wants it, because Warthin-Starry coats the outside of the H. pylori and makes them appear about 3 times bigger than they really are. So if you're looking at 20 or 30 or 40 or 100 of these a day, that makes it nice. Troubleshooting, again, just follow instructions. Make sure you have good procedure. That's pretty much all I can say about that. Giemsa, a neutral dye which combines methylene blue with eosin. You differentiate it with a weak glacial acetic acid. That's just a normal, just a regular generic protocol. And there you go. That's what your H. pylori look like with the Giemsa. And that's a really good stain. But you can see pretty easily how much quicker you could pick up on a silver stain than you can on this. I would like, if somebody could email me or something, I'd like some clarification on basically what is done now in the laboratories as far as screening tests before you go to IHC on a for H. pylori. Do you immediately go to IHC if you think you see it in the H&E? Because most pathologists will see tracks of it in the H&E. Or do you go to a silver and a Giemsa, and if those come up negative, do you then go to the IHC? I would really love to know something about that. See, there's the IHC, which of course is more expensive. So Giemsa troubleshooting. Jenner and Giemsa are neither very stable, so just make sure you make the solutions fresh. The glacial acetic acid step is very critical. You can over-differentiate or under-differentiate. You just won't get that contrast like you saw in that slide that I showed you. And as you know, it absorbs the stain, so it goes inside and it doesn't make the organism any bigger like the silver does. So you can blot instead of dehydrate 2 alcohols to keep the blue in there. Fungus. Most common to humans are Histoplasma capsulatum and Pneumocystis carinii. So histoplasmosis, it occurs when you breathe in spores. It kind of acts like flu. It can kill you if you leave it or untreated. It's common in immunocompromised patients. The best way to demonstrate it is Gridley's methenamine silver or Grocropp's methenamine silver. So the pneumocystis is known to cause a fatal pneumonia in immunosuppressed patients. The appearance of it came about with the emergence of AIDS. It's also best demonstrated with the GMS. Okay, so different from reticula and worthless starry, the GMS is an arginophin silver stain, which is the opposite of argyrophil. The arginophin refers to cells which can reduce silver without any kind of external aid. So the GMS relies on oxidation to form aldehyde groups, kind of like we saw in the PAS, but instead of using the weaker pyrotic acid as its oxidizer, it uses chromic acid as the oxidizing agent, although some people do use the pyrotic acid, which will do it. It might take longer. So then the groups act to reduce the silver ions to visible metallic silver. This is a little picture of it because GNS is an oxidation reduction kind of technique. So first of all, we oxidize in chromic acid to produce those aldehyde groups. This removes electrons from molecules. Then we remove the residual chromic acid with sodium bisulfide. Then our silver ions bind and self-reduce to metallic silver. That's kind of cool. Reduction adds electrons. Then we tone it in gold chloride to metallic gold for more clarity, contrast, and stability. We remove the unreduced silver, then we counterstain it. Here's the process. Believe it or not, this too can be automated on an open system. You just have to set it up, and you have to have a heated vessel on your instrument. Okay, so when I was teaching students at Florida Hospital, I put together this visual aid chart to kind of help because we were constantly getting our pneumocystis stains overstained, and the elastic tissue was like, kind of hiding everything. As the picture on the far right shows, that's over-incubation in silver. So if you kind of look at this, visual 1 is after 5 minutes, just to get into turn. 2 is after 10 minutes. You're starting to get those foamy areas. And then after 15 minutes, the background is light brown, the foamy areas darken, the pneumocystis are visible. And then after about 20 minutes, things get darker. You get the tiny brown lines that are indicating that your elastic tissue is starting to take up silver. So you might want to stop it. The pneumocystis are clearly defined. So when you stop it there and perform the rest of the stain, visual 5 is kind of what you end up with, a perfect GMS and not over-incubated. So basically, with like 2 to 3 minutes left, I just want to tell you that these are some people here, some research that I used to prepare this information, as I really didn't make it up myself. And I want to thank these folks for publishing things that are so helpful to us. If you have questions we don't get to and you have any information on that subject I mentioned, there's my email address, cjbearley@aol.com. I have totally enjoyed this. I hope you did too. Thank you.